Dear ESMO colleagues, welcome to the first ESMO Roundtable. It is a pleasure to moderate what will no doubt be a great discussion between some key opinion leaders, not only in our society, but in the world. Today, we will be discussing COVID-19 versus cancer, weighing up risk over time. Our panelists today are Professor Solange Peter, CHUV Switzerland and ESMO President, George Pentheroudakis, University of Giannina, Greece, and ESMO Guidelines Committee Chair, Professor Philippe Aptimos, Institut Jules Bordet, Brussels, Belgium, Professor Marina Garasino, Istituto de Tumori, Milan, Italy, and I'm your moderator, Gilbert Morgan of Sweden. Today's program will be divided into 3 parts for a grand total of 45 minutes. The first of the sections will be the precautionary principle, how to manage cancer care during the COVID-19 pandemic. Secondly, our discussants will talk about the scenario that awaits us after the pandemic. And lastly, we will open the floor for discussions. So without further ado, let's start with the roundtable. The first section is the precautionary principle, how to manage cancer care during the COVID-19 pandemic. We would like to start the section by asking Dr. George Pentheroudakis to give us an overview of the ESMO recommendations.
Good afternoon. I'd like to thank you for the invitation to participate in a very interesting roundtable. And I'd like really to wish to everybody to be strong and to remain hopeful for better days. So ESMO, as you know, produces clinical practice guidelines over the last several years in order to provide guidance to cancer health professionals managing patients with malignancies. But we currently live the COVID pandemic. It's exceptional circumstances. As you know, it affected societies. We loved ones, and it created a healthcare crisis, which is unprecedented. So a couple of weeks back, our president, Professor Peters, proposed to the community of cancer professionals, which is ESMO, to step up and produce adapted recommendations for cancer care during the COVID era. So we tried to figure out quickly how to do this. We created a rapid reaction task force, if I may call it this way, with guideline committee members and ESMO faculty experts. We first set up the definition of risk categories, patients, cancer patients who are receiving active therapy, who are receiving immunomodulating therapy, who have comorbidities, are, as you may imagine, at higher risk for COVID infection and for severe sequelae. And then we moved on to iterate a general framework of principles for prioritizing every aspect of cancer care. And these basic principles were, first of all, the condition of the patient, whether the patient is stable or not, the cancer insult, whether it is a life-threatening or an indolent disease, and of course, the perceived benefit of the cancer modality that we will propose to the patient. On top of this, as you can imagine, we have to add patient level and system level parameters, but this is more or less the story. So we used this algorithm in order to prioritize everything in cancer care: outpatient clinic visits, imaging, radiation therapy, surgery, systemic therapy, to 3 categories. These are the high priority category. We need to get this done now, irrespective of the crisis. The medium category, which are aspects of cancer care that may be delayed up to 6 weeks without a significant compromise of the quality of care or of the outcomes. And the low priority, which is which equals to watchful waiting, things that we may opt to postpone until after this crisis is over. So the users may visit the ESMO website. We have released within 2 weeks, 18 tumor-specific adapted ESMO recommendations for cancer care during the COVID era. And that's excellent. I'd like to thank all the experts and the contributors who did divert so much time during a crisis into this product. I think it is important to emphasize the fact that this is only a general framework. So this has been developed by ESMO in order to assist the physician and the patient towards a productive discussion that will hopefully result in a personalized care plan for the cancer patient. And the other thing I need to emphasize is that in several aspects, the level of evidence that we had to use is rather low, because it's only 4 months that we've been exposed to this virus, and we don't really know several things regarding, you know, the cumulative incidence of COVID-19 in cancer patients and the increase in morbidity or mortality for our patients. So it is important to bear that in mind. And also, I'd like to encourage the users to look up official guidance that may have been released by their national or regional authorities as well. More guidelines are coming up in the next few days.
Thank you very much, George. Now, Solange Peters and Philippe Aftmos will be talking about balancing risks at both patient level and at systems level. Solange Peters, please go ahead.
Thanks a lot. Following what George could describe about the systems put in place, it's quite important to try to understand, first of all, and I think one of the most important difficulties that was evoked by George is the lack of what we call evidence-based data looking at COVID and cancer. So we try to find logical solutions in an environment where we are lacking data at the time being. So let's keep it at a bottleneck or at a limitation on everything we're going to say today. More importantly too, I think every recommendation will be adapted according to where the patient is, what is the health system in place, and how is the health system surviving the pandemic where the patient is. And this is also subject to vary over time. As an example, remember how Singapore could really control the first wave of infection, and seeing now a second wave, which is amazingly fast and high. So let's keep in mind that geography and timing will redefine how you can really adopt behavior for the patient and for the system. But when you think about these two chapters on my thoughts, the patient adaptation of what you're supposed to do in the system, I think varying over time and with an intensity and I would say granularity defined by the environment, you have to keep in mind that to be logical in how you treat patients, first of all, you need to apply guideline with a case-by-case kind of scenario, and every of your patient has to be informed about our lack of knowledge, but also about the consent he has to give for every adaptation you would propose. Second, a logical thing is reduce visits. Whatever we do, having the patient visiting less by telemedicine, but also doing peripheral laboratory tests and giving oral drugs are all good things to reduce visits. Identify who are your patients particularly at risk. And here Marina Garasino is making a huge effort in collecting data to let us know who is the patient who is the one most vulnerable for the disease. And last but not least, depending where you are, you will have to reschedule and prioritize your intervention. Can you still do surgery? Can you do still some follow-up for chemotherapy, intensive chemotherapy? So all this priority rescheduling has to be done over time. On the system basis, of course, you have to revisit your clinical setting, limiting the point of entrances, doing triage stations, social distancing, and I would say safe waiting rooms. So many practical things. And last but not least, very important for oncologists, we need to revisit the opportunity of doing cancer research, clinical trials, Should we consider still that phase 1 trials are relevant at a time where the risk-benefit ratio is in the context of a pandemic? So I think all these kind of things have to be taken into account over time.
Thank you very much, President Peters. Philippe Artimos?
Hi, Gail, good afternoon. I would like to add that the ESMO recommendations are very valuable because they provide in certain cases day-to-day advice in specific clinical situations, because the discussion about mitigating the risk for the patient is sometimes on a case-to-case basis. We spoke a lot about lacking data, and this is a new pandemic, a new virus. As oncologists, what we know are the statistics and the results of the clinical trials that led to standard of care. So we know what treatments are the most impactful on survival of patient, on mitigation of symptoms. Sometimes patients with cancer are very sick, and a discussion is very important on the benefit risk ratio, because the patient can be a vector of the disease if they have many visits to the hospital, or even moving from home to the hospital. The patient is also at risk if our therapy is too toxic or can induce immunosuppression. So we need to balance that, and this is something new for us. And I think, at least in my practice, I apply a lot of shared decision making, spending a lot of time on the phone with the patient to discuss what we want to do. Now, regarding the system, this is also very important and can be different if you are working in a comprehensive cancer center where you only see cancer patients, or you work in a cancer center or a cancer institute within a general hospital. I know many of my colleagues where the cancer institute have accepted patients without cancer because they are close to a general hospital, and they need to help the general hospital in providing beds. You need to think of your ICU beds. They could be empty, and you usually use them as post-op after a huge surgery for cancer, but you might want to leave them empty because you might have your patient that might need ICU care because of the pandemic. So this has led to a lot of changes in our practice. I think the recommendations are very easy because they provide clinical scenarios, and we are going to work together and put our data together to see if actually this impacted positively or negatively our patients, because it's only follow-up that will tell us if we did the right decisions.
Thank you very much, Philippe. Now, George Pantherodakis will talk about taking into account patient preferences.
Thank you. Yeah, this is very important, because essentially medical practice is a contract between the physician, who provides the expertise and the skills, and the patient, who provides the personal perspectives, the preferences, and the informed consent. So I think the first step to be taken up, which is very important, is to provide a safe interaction and communication between physician and patient. It really depends on the local reality, the prevalence of the contagion in the region, whether you do it in a face-to-face meeting or via a virtual meeting technology. Well, I'm lucky enough in my country actually to have a rather low spread of the contagion, so we implement triage procedures and some policies for ordered arrival of the patients into the cancer hub, so we get to see them, we meet them. I think this personal touch is very important. So we then talk to the patients, and we have to tell them frankly about the disease, the prognosis. We have to tell them about the treatment and the value that we assign to the treatment, and also inform them on the pandemic risk and on the local problems that are there in the healthcare facilities where they're going to be treated. So after we do this, we have to take in the patient preferences. We have to involve the carers and the families if appropriate. And I think the most important product is a mutually agreed care plan. This is a crisis. So in my mind, a jointly mutually agreed care plan, which is realistic, which may be less than state of the art, but which can be implemented, is superior to an unrealistic state of the art care plan that is going to collapse. So these are exceptional circumstances. The most important thing is to listen to our patients and reassure them that we are going to be there to care for them, although we may have to implement some adaptations, as in wartime.
Excellent. Thank you, George. To end up this section, we would like to talk about the issues and challenging of interpreting the precautionary principle at a local level, relying heavily on the capacity of local regional health systems, shortages of resources, status of the pandemic, and patient mobility across regions. I would like to ask Marina Garasino first to give us her insights, and after her, I open the floor to the rest of our discussants for their viewpoints. Dr. Garasino?
Hello, everyone. It's a very hard period for everyone, and we are in Milano, and Milano, it is still the epicenter of the pandemic, at least in Europe, because here in my city, the cases are still increasing. In Lombardy are starting to decrease, but the situation here in my city is not improving so much. So what we are observing is that we are seeing that less patients are in the intensive care beds. So we think that maybe we understand something more about the disease, but still the situation here, it is very difficult. I work in a comprehensive cancer center, so we try to remain COVID-free, and we try to continue to treat patients. We stay in the hospital 24 hours per day, I think, and we try to give the possibility to all the patients who are in hospitals which are COVID positive to be cured. So we take care of the surgery, of the oncological treatments. So I think that in our organization is important to have some centers that can continue the activity. We can increase the cancer mortality and during the pandemic. So as you said, the organization is a very important situation, very clear situation in the waiting rooms with the distances. We have to provide the PPI for patients and the parents, so to guarantee to be safe as much as possible. So, and then I think that we have also to educate our patients and their parents about the self-isolation and about some rules. So I feel that we have not just a role of taking care of the patients, but also to educate the families and the patients to be self-isolated and to be safe. So I think it's a strong period, and at the same time we are also trying to continue the research, and I agree we select case by case the clinical trials and who are the patients that maybe if you have a placebo-controlled trial, you can avoid to randomize the patient in the placebo control. If you have a tyrosine kinase inhibitors where you are the only center in Italy that you have the trial, maybe it is worth it to risk to treat the patients. So we decide case by case and we speak a lot with the patients. Maybe I said many things, but
That was
7
excellent.
weeks with the COVID.
You are an expert on this. Do any of our discussants, would they like to add anything or discuss anything?
Maybe if I can continue, one important point
Absolutely.
is that if there was a very difficult paper 2 days ago on Science, the first name was Kissler, and they said that it is possible that the pandemic will continue until 2022, it was on Science, or 2024. So I think that to continue with the research also important, because we need to continue to take care of our patients also in this period.
Excellent. Thank you, Marina. George?
Thank you, Marina. What I would like to add is that it is very important to have contingency action plans in place. My experience was that the first week was tougher because we didn't know what to do. So you have to reinvent everything. You have to partition the staff into backup staff and regular staff. We did that. We work in 7-day shifts, taking into consideration the incubation period of the infection. And then you have to implement compartmentalization, if I may call it this way. A gut reaction initially was to try to rush and help everybody. It doesn't make sense. You have to have isolated compartments so as to control the infection. So I think for places that have not been affected yet very harshly by the contagion, the most important thing to do is to sit down with the colleagues, with the hospital authorities, and try to figure out and imagine and build up action plans for when the storm comes. Then you weather it and you become more experienced, and I guess Marina is leading us into that. And then I think another important aspect is that patients are scared, but if you comfort the patients, you make them allies, and they comply very well to the mitigation measures that are being taken in every place.
Excellent. Thank you, George. Solange?
One important point I made here, so Switzerland is also having a very high incidence, but the number of cases is lower because we have lower number of inhabitants, but we have been suffering in the French part quite a lot. And however, in a health system which was not completely overloaded, meaning that every activity could continue and the intensive care was never completely overwhelmed. So something which was more or less, thanks to the experience of the other one, prepared to accommodate and acknowledge the cases. But so I was in an environment where all the decisions had some time to be taken. It's an opportunity. And we immediately struggled with a comment that was done by Marina, which was about be careful not to worsen or not to provoke a specific oncological mortality by trying to be very protective. And here I'd like to stress something. When I was speaking about the lack of evidence, we have now 4 important series showing that oncological patients might be more often affected in terms of prevalence or incidence, and their outcome is probably worse. But we don't have any strong evidence that above or beyond the fact that patients have cancer and visit often the hospital, which is not good in a pandemic time, we don't have strong evidence that what we do against cancer, meaning chemo, surgery, targeted therapy, immunotherapy, adds anything to the danger. The danger is to be a cancer patient. So we have to be very careful that postponing might be a solution, but I'm not convinced that watch and wait is really an option in many lung cancer, for example, or hematological malignancy. So we shouldn't take short ways, because short way might also be under treating somebody who anyway is at risk because of cancer and hospital. So I think everything we decide, that's what we call the informed consent, has to be decided in detail with the patients, because we don't have any convictions that the decision-making process we make today are the right one. And unfortunately, it's probable we will know about it a little late according to what we need to decide upon. So that's one very important thing to me. On the other hand, we are defining who are the fragile and vulnerable patients in a confined environment, which is quite good, because today, and we'll cover it in the second part, we make our patient come to my service is clean, there's nobody in the bus, there's nobody in the streets, and he comes directly to the hospital. Tomorrow, in Switzerland is in 2 weeks, the same patient will come to the hospital, but everything will have opened again. So how will we be able to still protect vulnerable patients when we will reopen, you know, the source of infection in all societies? I was giving Singapore, but the other ones. So I'm even more frightened about our patients evolving in a free environment and in a perspective of a potential second wave, right? So all these considerations are really, we are observers there, and we hate not to know in medicine, but we don't know.
Correct. Thank you, Solange. Philippe, can you wrap us up? Philippe? Okay, Philippe is not answering, so we can move on to the next part, which is the second section. And that is what happens after the pandemic, what scenario awaits us. So this next question was addressed here to Dr. Panterodakis, and that is for how long should we postpone or put on hold cancer care?
Well, not indefinitely. This is not feasible. You know, this is a very difficult question because we don't know what's going to happen with the COVID pandemic. So I guess this is a challenge that will become an opportunity for us to adapt and to find solutions. In our general framework, we define as high priority these aspects of cancer care that have to be implemented immediately, even when you're in crisis. For example, a spinal cord compression, or you have a patient with a curative malignancy like a leukemia that is also life-threatening, germ cell tumor, you have to implement the therapy immediately. And there are the medium priority cases in which it is reasonable to postpone or withhold cancer care for a couple of months, I would guess, 6 to 8 weeks, again, with appropriate monitoring of the patient. And finally, the low priority cases, which you would postpone until after this is over, at least the first wave. But I guess the opportunity here is to perhaps revisit our model of cancer care. We're going to revisit several things. What is the value of our therapies? And we have the MCBS tool at ESMO that is going to become now, I guess, more relevant than ever. What is the utility of traveling? How can we exploit the various technologies that involve virtual meeting and remote collaboration? I guess we're going to have to settle also with a central model of cancer care in which you provide very specialized services that is going to coexist with a decentralized model for cancer services that can be provided to the patient close to home. I don't want to become overtly philosophical, but I would like to point this, perhaps we are also going to revisit the value of health and the value of social connection and solidarity. I think it is very ironical, the fact that the more we implement the social distancing as a measure to control the virus, the more we appreciate how important it is to have solidarity, to remain connected. So this is an opportunity. After this is over, we shouldn't forget these important lessons that we need to stick together, we need to work together, we need to work across borders, and we need to prioritize public health, research, and science.
Absolutely. This has been the silver lining to this horrible pandemic, is the fact that we're now collaborating in a completely different way, and we have been able to break down a lot of borders. Going on with our same topic, after the pandemic, what scenario awaits us? The next question is addressed to Philippe Artemos. What are the possible risks of dark statistics for cancer due to the pandemic-related measures?
Sure. So obviously, I can think of at least tens of reasons for dark statistics, and I hope that we won't get there, because we would have followed recommendations, some common sense, and these shared decision making. One topic I would not want to discuss in length is, for example, drug supply, oncology drug supply. This is something that can be problematic in the future. We've seen that logistics in clinical trials can be already problematic during the pandemic, and some sponsors have already put on hold their clinical trials due to that. So let's see what will happen in the future. We hope that that won't be a problem. We know that we delayed some procedures, we canceled some. So many of the countries have put a pause, for example, on cancer screening. So the question that is posed here, will we end up with more advanced cancers in the clinics in the coming months? Others, that patients that are not coming to the clinic because they are afraid of catching the virus. Some of them are symptomatic, but they are so scared that they won't say that. So in the coming months, will we have sicker patients in the clinics? And we know that this is going to be difficult to tackle. Another issue is reorganizing all the visits and all the follow-ups that were delayed. So we know the follow-up, the patients in follow-up that are in remission are maybe a lower priority now, and they are getting delayed, or we are using telemedicine. We know that in many cancer types, we don't have imaging that is systematic. For example, in breast cancer, apart from mammography, a patient in follow-up, we do not do systematically scans or PET scans. We rely on our clinical sense, on the questions we ask, on our physical examination. So when we don't see the patients, are we missing relapses? And again, we are delaying surgeries, some of them. So we are trying to safely delaying surgeries, but once we come back to normal, and I hope soon, will there be a waiting list of patients just coming in? So this is related to the delay in the procedures and therapies. But there are other things that we can think about. So in many countries, the population is confined. And what the data we are seeing that is coming out is that because of also the anxiety, people are smoking more, are drinking more alcohol, there is sedentarity. So these are all risk factors for cancer. So in the coming years, will we end up with more cancers due to this confinement? There's also the psychological distress, because our patients have a lot of issues and they are often accompanied, and some of them need to come to the comprehensive cancer alone. Some of them are home alone. So psychologically, this will add some distress. Because of the confinement, we know that in many countries, you have partial unemployment. It depends on the healthcare system who pays what, but in certain countries, we might think that there might be financial toxicity in the future. Families or patients that were partially unemployed that might not put their health because of, in the first place, because of some financial problems. And something that will be discussed probably later by Dr. Peters, the research funding and then the delaying in initiation of clinical trials. Some of the cancer drugs that we have in clinical trials can have a high impact and can provide a very large benefit for patients. This is getting delayed. So what will happen in the future? Will the research units lose also money, be in deficit? So this is something that's also like a black box to me. I think that we will need to put our data together, this real world data, to understand if we are going to end up with dark statistics. And I hope that we won't, because we are going to follow common sense and not forget that cancer is a very serious disease, and we should not just apply the precautionary measures to everything.
Thank you very much, Philippe. To wrap up this section, I would like to ask this last question to our President Solange Peters. And of course, I'm setting myself up here. So Solange, are we expecting a year without major advances in the field?
I was looking at this question in advance, and I was wondering what you mean by in the field. So I will cover 4 points here. I would like to speak about infectious research, infectious disease research, because one of the points will be, it might be an advance for the society. When we speak cancer research, I think it's important to speak also about real world evidence type of research and the social progress that we can potentially make out of it. Just to speak about the infectious disease part of it, whatever happens for oncology per se as a discipline, the society and the medical world will have learned a lot about infectious diseases, right? We knew about this big pandemic in the past. None of us has experienced it. And we know and we see from the countries where the first SARS epidemic happened, that the learning process is fast, efficient, and is a kind of a precaution and can prevent the catastrophe to happen again. Look, Korea, for example, when you listen to the colleague, how they could manage the whole story in a preventive, controlled and quiet way. Hong Kong did the same in a way that we could not adopt because we were not trained for that. There's a learning process about epidemics, about how to deal with this kind of spread of a virus that we will get to know how to do. So I think that's something at the level of medicine, which is of paramount importance for the future. So second thing is probably that we will also create, and again, here I quote Marina, but we will create evidence about what a virus of this kind, and it's a huge family and it's close to other families of viruses, affect fragile patients. It's cancer patients, it's elderly patients, it might even be the story of the kids, but we'll create a little late, unfortunately, but we will create these huge databases with thousands of patients telling you in a multivariate way what does provoke a susceptibility to this virus type of viral infection. For example, Marina is building a full registry in one disease entity, which is lung cancer. Very important because these patients accumulate the risk factors, but also in collaboration with CCC19 and ESMO, we're creating a huge across cancer database to try to capture all the differences which can be observed from one patient to the other one, thousands and thousands of global patients. So I think all these advances will create evidence in infectious disease. In terms of cancer research, it was well covered before, but I think we need to understand that it will have been put on hold probably for 6 months, maybe 9 months. Lots of pharma industry have completely stopped recruitment. It's defined by country, but even in Switzerland, many big pharma have stopped all the accruals across diseases for clinical trials. So we will lose 6 months. We will lose 9 months. But a provocative question, my feeling is that at the era of immunotherapy, the research has moved probably in the recent 5 years too fast, too redundantly in the way the trials were repeating each other, and maybe also too fast in order to have the sufficient follow-up of patients to exactly know what was the most beneficial strategy in each subgroup of patients. So maybe it's also a time to connect with the data, to summarize the data and to find a way to be a little bit more reasonable and scientific. in the way we'll continue to develop, for example, immunotherapy. So it seems a good side. I provoke a little bit, but I don't think that 6 months of delay will ruin cancer research, but might help us understanding what we've been doing, meaning spending billions in doing encore trials in many diseases, right? So I think we can sometimes and somewhere improve things there. This will restart for sure. There are also lots of economic kinds of opportunities here that will not be lost by the industry for sure. I think it's quite important for patients to have this starting again, of course, and this is one fact. For the research, it's one of the things. For the real world evidence, I think we will be able to catch up with everything which we can learn from the toxicity of what we do and the COVID infection. And I think it might be a way to be together, creating opportunity, creating articles, creating publications that we never met before. And this in conjunction with what I was telling with clinical research, even if we are not as active as before, what is good there, and Jill, you will agree with me, is that by having this reflection time, we will need good platforms to share the reflection. And it's not going to be face-to-face, even if I hope there will be an annual ESMO meeting. I'm not sure there will be an annual ESMO meeting. So we need to be able, real-world evidence or reflection around the clinical trial portfolio, we need to be able to build virtual congresses, virtual preceptorships, virtual workshops, master classes, and so on and so forth. And again, to be provocative, we might learn positive things out of the catastrophe we are experiencing now. Is not to say we'll never meet, but to rationalize what we have been doing around and running around the world all these recent years, me first, trying to think maybe there is a middle way there and we can communicate differently. Last but not least, the social progress. That's the only real positive point here. I think, and I think my colleague agree, we've never been collaborating this way. I have never approached a group with such a fast approval for a collaboration. We have a question, let's answer the question together. Usually it takes 6 months, a year, 20 lawyers, contracts. In these times, it takes 48 hours and everybody agrees. So it's amazing how we can be flexible, collaborate, adapt, share without any value or priority or personal agenda, just about creating evidence, helping patients, improving cancer care. So I think we have been learning that we can be even better researchers being together, and that's extremely important. Last but not least, the political point. I think it's amazing how we have been underestimating the value of a public health system in the recent years. I don't see any country in Europe which did not suffer from reduction of budgets, suffering from the lack of nurses, lack of doctors, the fact that we could not really do our job optimally. And suddenly everybody has to accept and even recognize that nothing can work if the health system is fragile. So let's try to keep it in mind. The next time a round of question about utility of public health system come, because they will come. They will come in Switzerland, in France, in Italy, in Germany, everywhere. Let's try to keep in mind how much it's important to have a system which is very solid and defend it not only now, but in 10 years from now.
Thank you very much, Solange. That was an excellent answer. I completely agree. I think it's wonderful how we have come together, especially with the use of not only social media, but all these tools to teleconference and the possibilities that are coming up. Like you mentioned, the virtual meetings. There's a lot of good that can come out of it. Not to mention, just thinking right off the bat, a lot of people have been thinking is just maybe we were traveling too much, and this is a good way to actually make a good impact on the environment, even though it's because of something else. It's good that we're doing it. And one of the last things that you mentioned with the healthcare systems coming from the US, I think this is a big wake-up call for a lot of us that are coming from America, that really, I mean, I came to Sweden precisely because I wanted a different healthcare system. I wanted to work somewhere else. And I am very glad that people are finally waking up to see that a strong reliable healthcare system is something that can get us through emergencies like this.
Yeah.
So thank you all very much. I would like to close up this section and move on to our third section. Are there any burning questions, discussions, or parting thoughts or discussions we'd like to take up? George?
Thank you. I can only echo what our president said. You know, being the hopeless optimistic, I think there are a few positive things that we can take with us. First of all, of course, our thoughts are with the families that have lost beloved ones. But the positive things is, first of all, life over economy. We had several leaders that actually said, we are going to lose lots of money. Okay, we'll make money later. If there is a loss of life that is preventable, we need to prevent it. And it's a good thing to actually remember our humanity. The second is solidarity. And the third is the value of science and public health, which perhaps our society has partly forgotten. This can be a reminder, it can be a triumph of science. We genomically deciphered the virus within 1 month. We cultured the virus within 2 months. We profiled the RNA polymerase of the virus within 3 months. That's unprecedented. And we'll come up with drugs and the vaccine in a few months. The safety requirements will probably cause some delay. So this could be a nemesis, but it could also be an opportunity for an unprecedented triumph, and we'll come out stronger from this.
Thank you so much, George. Philippe?
Yeah, I don't have much to add to what was said by George and Dr. Peters. I think that as an oncologist, I learned a lot from this pandemic, even from how I treat my patients and how I organize my care. So I'm sure that even though clinical research will have been delayed by a few months, as Dr. Peters said, I think we generated also new hypotheses that we will eventually investigate in the future. We are doing less but trying to do better. So probably that clinical trials, testing de-escalation therapies, being less toxic to patients are going to be set up in the future. And this will help our field move forward. So again, for me, this is going to be a positive step because we learned a lot from this pandemic.
Thank you very much, Philippe. One last word, Marina Garasino.
Yeah, just I echo what you have already said, because it's a period of improving and not just, but I just want to say something also on bureaucracy. I think that in this period, as Solange said before, we could see that things could be done also without so much bureaucracy. So I think that we must learn also from this part and to try to remove from the next period so much bureaucracy from our work, to stay more with the patients and to do the research with less costs and with everything. I can say just that I am on your same page, and it's great to be here together.
Thank you very much, Marina. With that being said, we thank our discussants. We have covered all our parts. Thank you very much, Solange Peters, George Petrodakis, Marina Garasino, Philippe Aftimos. Thank you for being here to talk about what has become a very pressing issue here in oncology. We know your time is valuable and our deepest appreciation for your efforts. We thank you, our colleagues worldwide, for your support and for being in the front lines of this pandemic. Thank you, everyone, and good night.